welcome Professor Paulus Kirchhof to the stage. He is going to speak to us this morning on the East AFNet trial and the judicious use of antiarrhythmic drugs in the management of atrial fibrillation. Professor Kirchhof is the director of the Department of Cardiology at the University Heart and Vascular Center, UKE, Hamburg, and also holds a part-time position as Professor of Cardiovascular Medicine at the University of Birmingham. He studied medicine in Heidelberg, Lille, Georgetown, and Munster, and after graduating, he learned and practiced cardiology at the University Hospital Munster and worked in Birmingham from 2011 until moving to Hamburg in 2020. Professor Kirchhof researches translational mechanisms and management of cardiovascular diseases, especially arrhythmias and heart failure. He is a highly cited researcher, an enthusiastic teacher, and a mentor for cardiologists and cardiovascular researchers. And we are really looking forward, Professor Kirchhof, to hearing your findings from the very important East AFNet trial. Welcome.
Well, thank you very much for these very kind introductory words. I'm flattered, and it's a distinct pleasure that I can tell you about the primary findings of the early rhythm control therapy in patients with atrial fibrillation trial. Now, this has been a major effort, and I'm actually presenting this on behalf of quite a few people who helped start, organize, and then deliver the trial. When I look back at my training period, atrial fibrillation was almost considered a little nuisance arrhythmia that didn't matter much. And you even find editorials with that title from the 1990s. But of course, that has changed a lot. And we know that atrial fibrillation is one of the major unresolved cardiovascular problems, that it causes many strokes, but also that we've come a long way. This is, I think, the first summary of what was at the time a very audacious line of research, where people gave warfarin at a high dose to thin the blood to prevent strokes in patients with atrial fibrillation. And it is remarkably effective. It prevents 2/3 of strokes. It actually increases survival. It prevents all-cause death by quite a margin. And that was the starting point of effective treatments for patients with atrial fibrillation. And we now know that we can actually replace vitamin K antagonists such as warfarin with non-vitamin K antagonist oral anticoagulants, so direct inhibitors of thrombin or factor Xa, and they are actually safer than the vitamin K antagonists. They are easier to use because there aren't that many needs for frequent laboratory checks, and they have a mortality benefit compared to warfarin that is probably driven by their safety. So I'll start by saying that anticoagulation is a cornerstone of managing patients with atrial fibrillation when they have stroke risk factors, which is the typical thing. About 90 to 95% of patients with atrial fibrillation are elderly and or have cardiovascular comorbidities that put them at high stroke risk. Now, there is more that we can do for patients with atrial fibrillation. And a few things, this is actually a list taken from a paper that was published in 1340, so over 600 years ago. There are a few things that we knew for a long time and that are intuitively important, and that is exercise regularly, don't eat too much, don't sleep too little, either don't drink alcohol or at least don't drink too much, and avoid unhealthy stress. In the 19th century, we had to add to that, don't smoke. Before that, at least in Europe, we couldn't. Because it was either we didn't have access to tobacco because either it wasn't here yet or it was very expensive. But once it became a mass consumption thing, we found out about the bad habit of smoking and how it damages your heart. We also do quite a few other things that can improve outcomes in patients with atrial fibrillation. And these include, amongst other bits, interventions to improve blood flow to the heart, PCI or vascular or bypass surgery, valve therapy, either through surgery or through interventions, but also treatment of hypertension, treatment of diabetes and other diseases that coexist in patients with atrial fibrillation. Of course, anticoagulation, as I told you, and we also have antiarrhythmic drugs and catheter ablation and rate control therapy. There is no evidence yet, and I think it'll be hard to generate, to suggest that rate control therapy has a prognostic effect on patients with atrial fibrillation, even though it improves symptoms, which is an important treatment goal, of course. And this is summarized in the 2020 ESC guidelines by the ABC scheme. A stands for anticoagulation or avoid stroke. Basically, to put it very simply, whenever you see a patient with atrial fibrillation who is not anticoagulated, you should ask yourself, why is this patient not anticoagulated? Should I not rather start anticoagulation? B currently stands for better symptom control, and that's where I'm going to talk about in the remainder of the talk. And that is the role of rate control and rhythm control therapy until August last year. And C stands for management of cardiovascular comorbidities. So treatment of hypertension, of diabetes, of heart failure, of chronic obstructive lung disease, but also lifestyle interventions to help people to lose weight, stop smoking, etc. Rhythm control therapy, and this is from the 2020 guidelines that were presented just before we published the EAST trial, actually at the same session at the ESC last year in August, is only recommended for symptom and quality of life improvement in symptomatic patients with atrial fibrillation. And that is the mantra that we've all heard based on evidence that was generated at the beginning of this century, mainly the AFFIRM and RACE, but also later the AF-CHF trial. So this was actually the picture when we started the EAST trial about a decade ago. So why did we start this trial? Even on optimal current management, including anticoagulation, rate control, and therapy of concomitant conditions, patients with atrial fibrillation suffer stroke, acute coronary syndrome, heart failure, and cardiovascular death at a rate of approximately 5% of patients per year. And you can split this up. There are about between 1 and 2% of ischemic strokes per year, 1 to 2% of cardiovascular death per year, 2% heart failure hospitalizations per year, and 1% acute coronary syndrome per year. And this is very consistent across observational data sets, healthcare data sets in Europe and in the US and in other continents. Previous trials failed to demonstrate superiority of rhythm control using antiarrhythmic drugs over rate control in patients with established atrial fibrillation. Already mentioned the AFFIRM and RACE studies and AF-CHF. Antiarrhythmic drugs and AF ablation are safe in patients with atrial fibrillation and concomitant cardiovascular conditions. As you know, or as those of you who worked 30 years ago will know, we used antiarrhythmic drugs quite differently in the 1990s than we do today. We have learned how to use them safely. And I think the more recent evidence bits for that are, for example, the ATHENA trial, one of the trials that led to the approval of dronedarone as an antiarrhythmic drug, but also in terms of atrial fibrillation, the MANTRA-PAF early AF, stop AF trials. But most importantly, the CABANA study. You've probably heard about the CABANA study that was conducted to test whether catheter ablation improves outcomes compared to antiarrhythmic drug therapy in patients with atrial fibrillation and concomitant cardiovascular conditions. So with a CHA2DS2-VASc score of 2 or more, if you want to approximate it. And this is the event rate, the primary outcome of the CABANA trial. 2,200 patients were randomized, and those randomized to drug therapy did not have a bigger benefit of the therapy than those randomized to catheter ablation. But what is really remarkable about that trial, conducted almost throughout the world, in the US and in Europe mainly, is that there were very few serious complications of rhythm control therapy. And that was not different between arms. So we know that rhythm control therapy is safe. And then the hypothesis of the EAST trial is really built on the simple observation that atrial fibrillation damages the atria. And therefore, an earlier initiation of rhythm control therapy and the combination of antiarrhythmic drugs and AF ablation should maintain sinus rhythm more effectively than the current delayed approach to rhythm control therapy. Now, this is one of my favorite pictures. It is a picture that's taken by Uli Schotten's group in Maastricht, and it shows you the right and left atrium of a healthy goat. I'm not going to talk much more about goats, but what I want you to appreciate is how beautiful, complex, well-organized, and suited to its function a healthy atrium is. Now, if you were to put this up on your wall in your living room, people would probably think it's a work of art. You would probably eliminate the labels. These are pictures that were taken at the time of atrial fibrillation ablation surgery, and they were taken from biopsies of patients who have atrial fibrillation. And of course, they are only biopsies, and the resolution is not so nice, but you can clearly appreciate that the structure of the atrium is completely lost, and that some of these biopsies actually don't even look like heart tissue, but look like something that is yellow and fibrotic, or that is black and thrombotic. So clearly, the integrity and the organization of the atrium is lost in atrial fibrillation. Now, taking all these things together, that leads to a very simple question. And that's what the early treatment of atrial fibrillation for stroke prevention trial tested. Does early rhythm control therapy improve outcomes compared to usual care in patients with early, recently diagnosed atrial fibrillation at risk of stroke? EAST's AFNet4 was a multi-center investigator-initiated trial. The legal sponsor was the German AFNet, and the trial was initiated by AFNet and the European Heart Rhythm Association. We had quite a few supporters, both public funding agencies and industry partners. But it was an investigator-initiated trial, and the funders did not have a role in the design of the trial. What did we do? We randomized patients at risk for cardiovascular events, so with a CHATS-VASc score of 2 or more, and with recent onset atrial fibrillation, defined as atrial fibrillation diagnosed within a year prior to randomization, to either usual care or to early rhythm control. Usual care consisted of guideline-conformed therapy as we are used to see it. So it was anticoagulation, rate control, supplemented by rhythm control only in symptomatic patients on optimal rate control therapy. Exactly as our guidelines tell us, and exactly as we have practiced it ever since AFFIRM was published. Early rhythm control consisted of anticoagulation, rate control, and either antiarrhythmic drug therapy or AF ablation at the time of randomization in all patients. In case of recurrent AF, then reablation was possible and adaptation of antiarrhythmic drugs. So really, rhythm control for everyone, compared to rhythm control only for those who need it because of symptoms. All patients received treatment of concomitant cardiovascular diseases. All patients were seen in person at 1 and 2 years follow-up, and all patients were followed up for event until the end of the study. EAST AFNet4 was a prospective, randomized, open, blinded outcome assessment trial. It had 2 primary outcomes. The first was a composite of cardiovascular death, stroke, worsening of heart failure, or acute coronary syndrome. So summarizing the events that matter for patients with atrial fibrillation, the complications, if you wish, of atrial fibrillation. And the second primary outcome was nights spent in hospital per year, which is a decent proxy of the cost of atrial fibrillation care for healthcare systems. A 20% reduction in the first primary outcome was deemed clinically relevant at the start of the trial. And therefore, the trial was powered at 8% to detect a 20% improvement in the first primary outcome. We estimated that we would need 685 events to demonstrate that benefit. 4% of the alpha was spent on the first primary outcome, 1% on the second primary outcome. An event review committee, blind to randomized group, centrally adjudicated all events. And sample size was estimated at 2,810 patients. In the end, we ended up, as you'll hear on the next slide, randomizing 2,789 patients. We planned 3 interim analyses. They were conducted by the Data Safety Monitoring Board after accrual of 25, 50, and 75% of all events with corresponding alpha spectrum. 2,789 patients were randomized in 135 sites in 11 countries. 1,395 patients were randomized to early rhythm control, 1,394 to usual care. All patients were included in the primary analysis as randomized. The patients were a typical cohort of all comers with recent onset atrial fibrillation. More than half of the sites participating in EAST did not have on-site ablation facilities. And some of them were actually practicing cardiologists working in their own practice and randomizing patients. Mean age was 70 years. Almost half were female. They were a bit overweight. They had a median Charts-Wasser score of around 3.3, 3.4. Approximately 30% had heart failure at enrollment. About 40% were enrolled with the first diagnosis. And importantly, from my perspective, 30% of patients, almost 800 of the 2,789 patients, were enrolled without AF-related symptoms. Anticoagulation and background therapy were delivered to a very high standard. Over 90% of patients were on anticoagulation without differences between groups. Over 85% of all patients received rate control therapy, and approximately 70% of all patients were on antihypertensive or heart failure therapy with ACE inhibitors, angiotensin II receptor blockers, or neprilysin valsartan. Patients randomized to early therapy received rhythm control therapy, almost all patients. 95% of the patients received rhythm control at the time of randomization. The vast majority, as you can see here, received antiarrhythmic drugs. 8% were treated with ablation as first-line therapy, and the others, approximately 85% of patients, received antiarrhythmic drugs. You can see that quite a few patients were treated with sodium channel blockers, and quite a few were treated with dronedarone, and the remainder were treated with amiodarone, and then there were a few others. At the 2-year follow-up, 2/3 of patients were still on active rhythm control therapy, and 1/3 had stopped rhythm control therapy. At that time point, almost 20% had undergone AF ablation, and about 45% of patients were still on antiarrhythmic drugs, with the same drugs, sodium channel blockers, amiodarone, and dronedarone being the main drugs. This treatment pattern was very different from the treatment pattern in usual care, where only 4% of patients received rhythm control therapy at the start of the trial, and that increased to 15% of patients, with about half of those receiving AF ablation at the 2-year follow-up. This rate, 15% of patients receiving rhythm control therapy, is very much in line with general atrial fibrillation registries, showing that about 15% of patients need rhythm control therapy to manage their symptoms. EAST-AFNet-4 was a low-touch trial. We observed patients for a median follow-up of over 5 years per patient. And we only had, on average, 2.1 study visits per patient in patients randomized to early rhythm control, and 1.95 visits per patient in usual care. There was a small difference between groups, mainly induced by visits at the start of the follow-up that were needed to adjust rhythm control therapy in patients randomized to early rhythm control. But overall, it was really a low-touch trial. Another thing that is important, and we are analyzing this as we speak, rhythm control therapy that was delivered was almost in all patients in line with the Class 1 recommendations of rhythm control therapy according to the European Society of Cardiology. 97% of patients were treated with rhythm control therapy following the Class 1 recommendations, and we had violations of those in only 3% of patients. I do think that this contributed to the safety of therapy. I've shown you here the flowchart from the 2020 ESC guidelines. You can compare that to the flowchart of the 2010 ESC guidelines, and you'll find that there aren't that many differences. There's one exception. Sotalol has sort of received a bit of a downgrading, and we actually had a notion in the protocol of the EAST trial that encouraged the use of other antiarrhythmic drugs than sotalol as first-line therapy. trial was stopped at the first interim analysis in March 2020. This funnel plot shows you in red the upper and lower boundary of the stoppage interval, and you can see in blue the observed hazard between the arms. And positive numbers show efficacy of early rhythm control, negative numbers show efficacy of usual care. Trial was stopped in March. It took us then 2 months of intensive work, actually during the first wave of the COVID pandemic, to collect all the events. And then we had the results and were able to publish and present them at the end of August last year. 249 out of 1,395 patients randomized to early rhythm control experienced a first primary outcome event. This was 21% lower, 1/5 lower than the 316 patients with the event randomized to usual care. A highly significant difference, a hazard ratio of 0.79. Each component of the first primary outcome was numerically lower in patients randomized to early rhythm control compared to those with usual care. Fewer cardiovascular deaths, fewer strokes, fewer hospitalizations with worsening of heart failure, and fewer hospitalizations with acute coronary syndrome. The uncorrected hazard ratio 95% confidence interval for cardiovascular death and stroke did not cross the line of unity. There was no difference in nights spent in hospital, the second primary outcome parameter, 5.8 plus minus 22 nights in patients randomized to early rhythm control, 5.1 plus minus 16 nights in patients randomized to usual care. A very high proportion of patients was in sinus rhythm at the 2-year follow-up. 82% in those randomized to early rhythm control, 60% in those randomized to usual care. Usual care was highly effective in rendering patients asymptomatic. 3/4 of all patients were asymptomatic, estimated by an error score of 1 at the 2-year follow-up, without differences between randomized groups. In the overall study population, we also did not find a difference in left ventricular function between group or in quality of life estimated by general quality of life questionnaires. We are analyzing this for subgroups, of course, and we think that we'll learn quite a bit about this in the future. What about safety? The primary safety outcome was a composite of stroke, all-cause death, and predefined serious adverse events of rhythm control therapy. So we searched actively for complications of rhythm control therapy throughout the trial. The overall safety outcome was neutral. 231 patients had a safety outcome in early rhythm control, 223 in usual care. Stroke was less common in patients randomized to early rhythm control, and there was even numerically fewer deaths, although that was not statistically significant in patients randomized to early rhythm control compared to usual care. There were more complications of rhythm control therapy in patients randomized to early rhythm control, but there were few. There were less than 30 patients who had a serious adverse event of antiarrhythmic drug therapy over a 5-year follow-up in 1,395 patients. And there were 10 serious adverse events related to atrial fibrillation ablation in patients randomized to early rhythm control. That was more than the 9 events due to antiarrhythmic drug therapy and 2 events due to AF ablation in patients randomized to usual care. We performed a very careful, extensive, predefined subgroup analysis, and we did not find any interaction between the treatment effect and subgroups. So early therapy appeared to be effective in young and old people, in men and women, in those with overweight or normal weight or underweight, in those with and without diabetes, with and without kidney disease, with and without stroke, with low and high CHA2DS2-VASc scores, with and without heart failure. Importantly, from my perspective, also there was no interaction with symptoms. The treatment was equally effective in asymptomatic and symptomatic patients. And there was also no interaction with rate control treatments or with the type of center. As I've told you at the start, we only enrolled approximately a third of the patients, a bit more, in patients who performed ablations themselves, so who were experienced in rhythm control therapy. And 2/3 of the patients were randomized in patients without on-site ablation facilities. I want to highlight this once more. There was really no detectable interaction between symptoms measured by the ERA score, where ERA 1 is completely asymptomatic and ERA 4 are disabling symptoms, and the treatment effect. And as I've already told you, both treatment arms, both usual care and early rhythm control, led to very good symptom control at the 2-year follow-up. There's also no perceptible difference in quality of life estimated by general quality of life scores. So usual care, as we practice it currently, is very effective in controlling symptoms, but it does not convey the clinical benefit for stroke, cardiovascular death, heart failure hospitalization, and ACS that is conveyed by early rhythm control. Now, you've seen this chart before, but I wanted to show it again because it tells us the different ways that we can use to deliver rhythm control therapy. There were centers who offered AF ablation early on, and that worked. But there were many centers who started rhythm control therapy with antiarrhythmic drugs, used in 85% of the patients at the start. These are the yellow, green, red, and orange bars in this graph. At the 2-year follow-up time on the right here, you see that about 20% of patients had undergone AF ablation, probably due to failure of antiarrhythmic drug therapy. But the majority of patients, 45%, were still on antiarrhythmic drug therapy. This plot shows you the time to first ablation, and it tells you the same story. At the start, there were quite a few patients who received AF ablation, but only in selected sites. And then over time, the number of AF ablations increased. But at the end of the at the 2-year follow-up, 240 of the 1,395 patients randomized to early rhythm control had undergone an AF ablation, and the others, over 1,000, were managed without AF ablation. So in conclusion, an early initiation of rhythm control therapy reduced cardiovascular outcomes in patients with early atrial fibrillation and cardiovascular conditions without affecting nights spent in hospital. As expected, the early rhythm control strategy was associated with more adverse events related to rhythm control therapy, but the overall safety of both treatment strategies was comparable. These results have the potential to inform the future use of rhythm control therapy, further improving the care of patients with early atrial fibrillation. I'd like to thank all participating patients who stayed with us, the first ones actually for 9 years, the local study teams, the staff at AFNet and CRI, all committee members, and the financial supporters of the trial who are listed below. And I think, and it's the opinion of the people who coordinated the trial, that systematic and early initiation of rhythm control therapy should be part of the management in all patients with recently diagnosed atrial fibrillation and concomitant cardiovascular conditions, in addition to oral anticoagulation, rate control, and treatment of such conditions. Or to put it simply, whenever you ask yourself whether you should initiate anticoagulation in a patient with atrial fibrillation, you should, from now on, also ask yourself whether you need to initiate rhythm control therapy. I look forward to discussing this with you, and thank you for your attention.